So there will be a granulation tissue within this socket. We may have to clear it. Okay. Because inside the socket, whether it is clean or there is any contamination for in body, we don't know. So we have to ask the patient during accident, it is a clean or contaminated wound. For example, if he fell on the inside the home, so it is not a major issue. But if it's, the accident happened in a playground or road with a lot of dirt, or if the dirt also gone inside the mouth during trauma, then the socket might possibly be contaminated. If it is inside some indoor, it will be a clean wound. The tooth will be knocked out. That's it. So there may be some dust or sand. We don't know. We are not sure. So we have to ask this history. So better what we'll do is we will curate the socket. Okay, we will curate this, remove any granulation tissue, and we will create a. We will consider this a pure extraction site implant. We have to consider that we are extracting and placing implant. So during trauma there was chipping of 1 and 2, and you can see the alveolar bone fracture. Can you see the alveolar bone fracture? They have been fractured, but they are not very much displaced, they are intact. So the main thing, we should not open the flap, because if you open the flap, these fragments will come out. So we have to retain the flap. Even while curating out, you should not give major pressure towards the labial side. This may, you may recreate the fracture again. Okay. So luckily the crustal bone is intact. There is not much crustal bone loss because of trauma. Okay. So replacing a single incisor is always quite a risk, because only one tooth. Risk of failure is more in single implants than with multiple implants. Here if you see, this might be the root apex. So beyond the root apex there is only 2 or 3 mm. Suddenly the nasal floor comes. Immediately the nasal floor comes beyond the apex. So by nature itself, the patient has got a less basal bone. Okay. Some patients beyond the apex, the nasal floor will be very far away, but here, yes. See, the patient has got a zygomatic fracture also. You can see the fracture line, but it is not displaced. The patient might be not aware. If you see the right side, there is no fracture. It is clean. Okay. But the left side, here some fracture. And so what you have to do is, when the patient comes, you have to put your finger here, palpate. The patient may feel tender, feel pain. And you have to ask history, whether the patient has got any nose bleeding. Did you ask history, nose bleeding? No? Okay. So during the initial trauma, the patient might have got nose bleeding and redness of eye. Is the patient having redness of eye now? No? Okay. So nose bleeding, conjunctival ecchymosis, tenderness in the buccal sulcus, these are all symptoms. But even if it is a fracture, we don't have to worry, because it is not displaced, it is not a complete fracture, it is no partial crack. It will heal by itself, we don't have to do anything. So the patient has got trauma in the chin, trauma in the incisor, and apart from the trauma here. So we have to doubt whether it is a road traffic accident or some fist fight. Okay. Okay, we'll see. So the patient has got a low smile line. In that aspect, it is a less risk case. Okay. It is not a high smile, tummy smile patient. So the only difficulty is getting a good implant stability. That too after extraction, almost it is empty place. So whatever bone we are going to engage, it is the palatal bone or the towards beyond the apex bone. So beyond the apex, this bone, palatal to the socket, this bone, only this bone. Other parts of the implants will be exposed in the socket. So we will plan first axially. Okay. Fortunately for this patient, palatally there is good bone, right? There is enough volume of bone palatally, but you have to tilt, go parallel to the palatal bone. Okay. The nasal floor is good. It is around 1,600, something like this. So around 17 it shows. Okay. The more palatal you go, the more longer implant you can place. But if you reduce the palatal angulation, you have to reduce the length. You can place only 13 mm implant. Okay. But the more you palatally go, the more longer you are getting your implant, but the more labial your abutment will come. You will see now. Okay. The more, but this is okay. A small mild bending and mild abutment preparation will do it. Okay. So the only drawback here now of this plan, one implant, this part here it will be exposed. Okay, the compressive implant gets stability from the apex, body and the crestal part of the implant. But here we are getting only stability from the apical and the middle part, the body part, but not from the crestal part, which is also an essential part. Because only the part of the crestal bone is embedded in the bone, but most of the implant is exposed within the socket. So almost 4.1, 16 or 18. You go more palatally, you can. So you have to keep on finger palatally and go drill along this. You will see the 360-degree view. So you have to check the proximity of the canal. Okay. So this is the canal. We are quite safer. So just axial implant, axially drilling, and if you see palatally where we are exiting nasal floor. If you see here, you see now we are almost in the middle of the palate. Okay, almost near the premolar or canine region. Okay, that is okay. One more thing is, see the nasal, midline nasal septum here. You can engage in the nasal septum area also. That is another plan. Okay, but for that you have to tilt the implant towards the midline, and you have to come towards the labially. Okay, you will see. If you see, this is the midline, right? You can see the nasal septum. It is very prominent, very good, but only in the front area. Behind, it is not there, right? So if you want to engage the nasal septum area in the midline, you should not do the palatal angulation, right? If you go palatal angulation, you cannot get engaged in the and not only that, you have to tilt slightly towards the midline, exactly towards the midline. Here also you can place a 18 mm implant, but here the abutment angulation will come little favorably. Okay. So the drilling you have to start from the mesial wall of 2-1. Okay. Mesial wall of 2-1, angle towards the midline and not very much towards the palatal area. And we have to see the nasopalatine canal. Where is it? It is not present here in this view, right? We will see the nasopalatine canal first. See the so this is the crown level, right? This is the incisive papilla level. Comparatively, the incisive nasopalatine canal is very small. That is good actually. Okay, this is the incisive canal, nasopalatine canal. So it is not very much big. That is one goodness here. The nasopalatine canal is very big. Then we have to see this is the nasopalatine canal. Okay, can you see? It is very small actually. So in way that is a goodness, positive for us. So just in front of the nasopalatine canal, you can place a very good implant. If you place like this, almost 90% of your implant is surrounded by bone. Okay. The only thing is you have to start the drilling from the mesial wall of the central incisor. Mesial wall of the central incisor and towards the midline, right? So we have two options now. One is engaging the midline nasal septum. The second option is using the palatal bone. So one is axial implant, one is the tilted option. So going axial is straightforward. There is no much thing involved. But going tilted, we have to be very careful because it is a little unconventional. We have to exactly catch the nasal septum and you should not enter the nasopalatine canal. So these are the issues. But if you go towards the nasal septum area, you will get excellent stability. Okay. These are all the ideal cases for navigation actually. Okay. We will see. What we can do is, we can do pilot drilling and we can take X-ray to confirm it. Then we can place implant for this patient. So one option is axial implant, catching the palatal bone. Another option is tilting it mesially to catch the nasal septum. And one more option is also there. You can place two implants. You can place two implants. Okay. One tilted, one axial palatally. But of course, one implant will be compressive and one implant will be BCS design. But this is placing too much metal in this tight spot. Okay. In one way you may go into the canal or you may injure the lateral incisor. So placing two implants is not a good option. And one more option is there. What you can do is, you can see in the midline there is a good length of bone is here, right? If you, the moment you go axially, you are losing loss of bone, lot of bone. So if you are going axially, you have to tilt as much as lateral as possible. So what you can do is, you can select a BCS-EX design of implant. It will engage more better, no? Because of the design type. That also we can plan. So that is also one more option. Okay. Doing any of this, what you have to do is, after anesthesia, you are going to cure it. During curating, check the labial plate first, whether it is intact or any small pieces may be floating in the socket. You have to check that. Then you can decide. So 4 options we have got. One is axially placing a compressive implant or axially placing a BCCX implant. Third option is a compressive implant toward the midline to catch the nasal septum. Fourth option is 2 implants, which we are not going to do. Okay. So intraoperatively we will decide which option we are going. Mostly we will go to catch the nasal septum.